Welcome to NWAETC Project Echo. First, we have a presentation by Shirisha Danareddy. If you could just say a quick moment to introduce yourself and then move on into your presentations, that'd be fantastic.
I think most of you have heard from me before because I'm usually here every other week, but I'm Shirisha Danareddy. I'm Assistant Medical Director at the Madison Clinic here in Seattle. And I've been given the task this week of talking about all of STD testing in about 10 minutes, so that's obviously going to be a challenge. So I'll hopefully hit the highlights, and because I know that there are three interesting cases that we want to get to today. So just as an overview about STDs and HIV, we know that people with HIV don't infrequently get STDs, and we know that there's some interaction between the two in that STIs may increase the transmission and acquisition of HIV, and there have been a number of studies looking at this, particularly when it comes to increased shedding in the genital tract of HIV in patients with other STIs, that there's an increased risk in patients with gonorrhea, chlamydia, and trichomonas of HIV acquisition, that genital ulcers increase HIV acquisition, and even asymptomatic HSV shedding or infection can increase HSV genital shedding as well. And there have been a number of studies, like I mentioned. And we also know that potentially that STIs can manifest a little bit differently in patients with HIV. For instance, in HSV genital ulcer disease, you can see more prolonged chronic ulcers in patients with very low CD4 counts, which is unusual in that patients with preserved CD4 counts, you see natural resolution of the lesion. So what I wanted to go mainly through is the STD guidelines, treatment guidelines, which were updated in late 2010 about screening. And we see a lot of MSM in the Northwest in terms of HIV positivity. That's the main risk factor. So clearly we want to be screening all male MSM and sexually active young men as well in high prevalence settings. And then in women, it's a little bit less upheld in terms of STD testing or screening. Generally, all sexually active women under the age of 25, we should be testing for gonorrhea and chlamydia, and this is probably not done routinely enough. That's because the rates of chlamydial infection are fairly high in this group, in particular demographics as well, like African Americans and minorities. And then women older than 25, if at increased risk, and that includes whether you've had a previous STI, multiple partners, commercial sex work, drug use. HIV isn't specifically on this list, and that's why there's a controversy in terms of how frequently to screen HIV positive women older than 25 if you don't meet these other categories. So how and where to screen? So in terms of where we do testing or what we test, it's important to ask what kind of sex you're having, and this is a discussion that should be incorporated into every primary care visit of when you're talking about asymptomatic screening. So you want to be, if you're seeing somebody who's MSM, you want to know, do they have oral sex, are they top, bottom? You want to be really specific and then screen specifically for those sites. In our clinic, we have, it's easy to do a nucleic acid test of the urine because it doesn't really involve much on the provider part. You just have the patient give a dirty urine sample. But doing a rectal swab for nucleic acid testing or culture is a little bit more invasive. There's sometimes patient resistance and provider resistance to do those things, but it's really important to ask and do those things. At the STD clinic here and in some other areas, what they're doing is self-collected specimens for some of these other sites, for instance, the pharynx and the rectum, and having increased uptake of testing with self-collected specimens. So we may hear more about that in the future. Syphilis screening, there's non-treponemal and treponemal, which I'll go into a little bit more in a subsequent slide, given that some areas where you might be practicing are still doing RPR or VDRL as the primary test, whereas some areas are doing syphilis IgG, which is a treponemal specific test, as the initial screen. So since we're talking about syphilis, just to quickly go through the stages of syphilis, as we all know, has been mentioned at previous echo sessions, there is a dramatic increase in the number of syphilis cases in the Northwest as well as on the West Coast, particularly in the San Francisco area among MSM. And there was actually even a recent public health report in King County about 2 heterosexual teenagers, high school teenagers, who were presented with syphilis, as well as 2 congenital syphilis cases. So outside of the MSM population, which has everyone worried, of course. If we are lucky enough to pick it up during the primary stage, usually it's a painless ulcer. We've seen some pretty large ulcers, penile ulcers, genital ulcers with primary syphilis in the past few months. You can make the diagnosis here if you look at the lesion, scrape the lesion, and look at it with a dark field microscope. Most people don't have that available. We do have it available here at the STD clinic, but it takes some skill, and I admit that I don't have that skill to look really carefully at those lesions and pick up those spirochetes on dark field exam. The other test is looking at RPR, which is generally pretty sensitive, and but you can see negative tests if, for instance, the burden is very high, and which is called a prozone effect, and if you dilute the sample, you can see positivity. Secondary stage, we have seen this not infrequently as well, where people present with rash. Someone was diagnosed just recently, just 2 weeks ago, with a drug rash to an antibiotic, which was actually secondary syphilis. And when you looked further, he had mouth mucus patches in his tongue and condylomata lata in his genital area. So this is a classic secondary stage, which usually happens weeks after acquisition of syphilis. Most of the time when we're doing screening, we're doing it on obviously asymptomatic individuals. And so early latent is within a year. So if you've had an RPR, some other syphilis testing in a year, and then within the year, and then a subsequent test is positive, that's called early latent. And then late latent is when you don't know the results of a previous test, or they haven't had previous testing and now they're positive. So that's late latent or latent of unknown duration. And the reason it matters is because the treatment is different, which I'll talk about. We fortunately don't see much tertiary syphilis, which is more of an immune-mediated phenomenon with syphilis. And what do we know specifically about HIV and syphilis? We know that all patients with syphilis should be tested for HIV, as patients with syphilis have a higher incidence of being diagnosed with HIV as well. And whether there's a more rapid progression of syphilis is still under debate, and there's a big study called the Charter study that looks at this, or a neurosyphilis HIV study as well. We know that the alternatives to penicillin haven't been well studied in this population, and there may be some association with improvement in clinical outcomes in patients on antiretroviral therapy. As I alluded to about neurosyphilis and HIV, there is a large study that looks at this that's ongoing. And the question is whether people with HIV have more of an inclination to have neurosyphilis when they're diagnosed. And this could be manifested by fairly subtle neurologic symptoms, sometimes otologic symptoms, ophthalmologic symptoms, so people who've presented with monocular blindness or hearing loss, that's considered neurologic involvement of syphilis as well. The 2010 guidelines have really eased up on who to do a lumbar puncture on. So in the past, we've used CD4 count thresholds, as I mentioned here, or high RPR titers. We're not so stringent about these criteria as much anymore based on the new guidelines, and especially in the absence of any neurologic symptoms. Of course, if anyone has neurologic symptoms, they should be tapped. In terms of what kind of testing, non-treponemal testing had been the standard to do the initial screen, mainly RPR in most areas. And then if it's positive, then a quantitative titer is measured. And then we use that titer to follow response. And over time, it usually goes back to negative or non-reactive. However, some people are what we call serofast, where they could have persistent low-level titers. Treponemal-specific tests like EIAs, which is bolded here, which is what we are using in our area now due to cost constraints and also decreased labor involved in doing the testing. It's a qualitative test. There's not a titer for this test, and it remains positive over time. So if you have a patient who's had syphilis in the past, this would not be the test to do because it's going to be positive. You should move towards an RPR quant or a VDRL quant, whatever is available in your area, because a repeat syphilis IgG isn't going to be helpful. That is done as an initial screen, and then what happens is people get an RPR titer. There was a great MMWR that looked at this reverse algorithm testing where we're doing treponemal-specific tests that came out in January, February of 2011 that I think has been referenced before in echo sessions, and I can probably get you that reference again. So it just depends on what you're doing in your area. And quickly, just to go through the treatment, it's a preferred treatment is benzathine penicillin, 2.4 million units, times 1 for early, latent, or symptomatic. And then you can use, for late latent, it's the 3 weekly injections of benzathine. You can use doxycycline as an alternative if you've got severe penicillin allergy. And then for neurosyphilis, we really try to desensitize to penicillin if possible because that is the standard and there's really not much data with alternative regimens. However, we have used ceftriaxone as an alternative. There's also, even though IV is the preferred, you can use IM with propenicid as an alternative. Just quickly to go through genital ulcer disease or urethritis, not genital ulcer disease, but urethritis. The differential is usually gonococcal or non-gonococcal. Most of the cases are chlamydia, so I'll go through those. We have gram stains in our clinic, and I'm sure you guys do too, and we could quickly make the diagnosis of gonorrhea, but I have to say that a lot of people don't do that anymore since we have nucleic acid testing that comes back fairly quickly, and so it's less invasive. It doesn't involve a urethral swab of any sort, which can be viewed as somewhat cruel to patients. So just the dirty catch urine is what we're mostly doing. And as we all have probably heard in the news, in terms of drug resistance, there's a lot of stuff in the media about gonorrhea and its decreased susceptibility to currently available therapy and increasing resistance that's been shown. So currently the guidelines for gonorrhea or urethritis in general is ceftriaxone 250 milligrams IM as the preferred. There are a couple of alternatives, cefixime probably being the main one in terms of availability, plus azithromycin to cover other organisms, non-gonococcal organisms. And then here are some alternatives. And in terms of repeat testing, we recommend that repeat testing be done 3 to 6 months after the treatment. And it's mainly because these patients are high risk, right? They've already had an STD. We should be testing again to make sure that they haven't reacquired another STD. In terms of test of cure, we don't routinely do that, but there are some exceptions to that: pregnancy, non-adherence, persistent symptoms, or you suspect some reinfection in them. And because we're doing nucleic acid testing, we don't get cultures, and so we don't get susceptibility testing. So if you are concerned about resistance, if someone's not responding to therapy, it would be an opportunity for you to get a culture of whatever site, rectal, pharyngeal, a urethral culture, to look for sensitivities if you're concerned and they haven't responded to therapy. So briefly, just some key concepts. Really important to take a detailed sexual history, and that's really should be part of primary care in general for HIV-infected individuals. Nucleic acid testing is really taking over as the preferred test. And the oral, don't forget about these other sites like oral pharynx and rectum, and remember to test those and treat those appropriately. And then remember about gonorrhea resistance, and dual therapy is recommended even in the absence of a positive chlamydial test. And really these recommendations don't differ that much in terms of HIV positivity versus negative men. And the resources really, the guidelines are pretty clearly laid out in the 2010 STD treatment guidelines, and I'd refer you to those for any questions too.